guys, welcome to our next episode of Head to Total, the podcast that pulls back the curtain on all things medical. I'm Colleen Young and excited today because we have a repeat guest. Based on popular demand, we have invited back Dr. Jeffrey B. Klein, who is our well-known podiatrist with Mendelsohn Kornblum Orthopedics in Southeast Michigan. Dr. Klein, thank you for coming back and talking with us.
Good morning. Thank you for having me.
Dr. Klein, we had so much in the last podcast that we're glad you're back because, we went through my feet and the disaster that are my feet. And now we've come up with a lot of questions for you. So thanks again for coming back and taking time out of the busy schedule and stopping bunion surgeries on my feet to do this.
Thank you. And thank you for swearing never to wear shoes like you wore last time.
Yeah, I lied to you, Dr. Klein. I love you dearly, but I lied right to your face. Because the shoes I have on today, Dr. Klein, you can actually see the bumps along the side of my feet.
Oh, no.
It's not a pretty thing. Not a pretty thing. But listen, enough about my feet and the agony that is my feet. What's the deal, Dr. Klein? What's going on with the kids and the heel pain? Is it plantar fasciitis? Is it heel spurs? What's going on?
Okay, usually children who have heel pain do not have plantar fasciitis or heel spurs. It's usually a condition that is called Sever's disease, or it's an osteochondritity. Basically, what happens is as kids are growing, growth plates are open. When you look at an x-ray of a child, there are lots of joints, of course, in the foot and ankle, but there's also growth plates that are open that look like joints. As a child gets older, these growth plates will close as they stop growing. Girls a little bit quicker than boys, you will not see the growth plates any longer on x-rays. But for some reason, it seems to be mainly in boys, but girls can get it too, somewhere between the age of 8 and 12 years old, they can develop heel pain. It can start off with one heel and go to the next heel. Kids don't usually complain of pain, so it's a pretty severe and debilitating type pain. It's usually common this time of year where people seem to walk around without shoes on or in flip-flops, or the shoes are getting smaller and they're not fitting as well. What happens is the growth plate on the bottom back of the heel, the apophysis is what we call it, gets inflamed and it gets very, very painful. The pull of the heel cord on one side is pulling at this growth plate on the back of the heel upward towards the knee, and the pull of the plantar fascia or the ligament on the bottom point is pulling in the opposite direction forward. And what happens is this growth plate becomes very painful. There's many different reasons that we theorize that causes this. Some people say it's a lack of blood flow to this growth plate. Not that they have poor circulation, but it's just not an area that has a lot of blood flow to it. Some pediatricians will call it growing pains. These types of problems can happen in many bones in the body, not only the heel. When I was younger, I had it on my knee, and it's called Osgood-Schlatter's disease. But basically, what it is, it's a very painful condition, and it requires rest. Rest means staying away from sports. Rest means wearing good supportive shoes. Sometimes we'll recommend a heel cup or something to control the biomechanics or the way the child walks. A lot of times we'll recommend anti-inflammatories, something like an ibuprofen. And a lot of times we'll recommend heel cord stretches that will actually take the tension off of this growth plate. Usually rest and staying out of sports for a week or so will usually get rid of it pretty quickly. A lot of times it is not going away rather quickly, and sometimes we'll put these children in a cast for a short period of time, and then after that we'll control the biomechanics or the way they walk with a pair of custom-made orthotics, and sometimes we'll actually send them to physical therapy, where they work on various modalities to get rid of or to maintain this heel pain away period.
So, Dr. Klein, you said children ages 8 to 12, correct?
Yeah, it's most commonly seen in children's 8 to 12 years old. When these patients come into the office, we'll always take an x-ray to rule out other things like fracture or other conditions. But most of the time, the diagnosis can be made just by history, where a sudden onset of pain in a child who's been exercising a lot more, or playing a lot more sports, or wearing the wrong shoes or no shoes at all.
Is it predominant in males versus females just because of growth spurts?
I think it is. I think that is the reason why, but I'm sure there's many theories of why it's more predominant in boys than girls. But it's a very common condition, especially this time of year.
Transitioning from the back of the foot to the front of the foot, is that tight shoes and the rubbing? Is that why people get ingrown toenails as well?
Well, that's one of the reasons that people get ingrown toenails. There are many reasons that people get ingrown toenails. The one is improper fitting shoes. I remember when my children were rather young, it seemed like I was at the shoe store every 3 weeks buying them new shoes, as they seemed to grow out of shoes rather quickly. And that's one cause. Another cause is hereditary factors. People who have ingrown toenails, a lot of times their parents, grandparents had them also. And another reason could be improper cutting of the toenails. Toenails should be cut straight across. When you talk about kids and ingrown toenails, a lot of kids will pick at their toenails and they will cause themselves an ingrown toenail. But as I was saying, toenails should be cut straight across. If they bother you, or if they bother the person in the corners, then they can be filed into the corners, or by coming into the office, and they can be treated in many different ways to take care of the ingrown toenails.
Does an ingrown toenail happen at the front of the toenail all the time? You indicated that it could happen on the side of the toenail too?
Yes, it is usually on the side of the toenails. If you look at your fingernails or your toenails, they're semicircular or they're rounded off to the sides. And a lot of people who trim their toenails, they cannot see the corner of the toenails or the sides of the toenails, so they trim it out and they leave a little hook in the corner that they can't see. We call that bathroom surgery, and we advise against that. And basically, what happens is as the nail grows out, the hook or the corner of the toenail will grow into the flesh of the toe or the sides of the toe and cause a lot of pain. It causes irritation, inflammation, and of course can lead to an infection. And you want to try and avoid the infection, but there are different treatments for the chronic recurrent or ingrown toenails that come back over and over again versus the ingrown toenail that just occurred once because they trimmed them improperly the one time.
So go back for us, Dr. Klein, about the bathroom surgery, because I think a lot of people try to do a lot of manicuring of their feet so that they don't have to come and see you and they don't have to show you their feet, which is absolutely ridiculous because one of the best things you could do is go to a podiatrist. In fact, Dr. Klein, at my nail salon, they recommend Dr. Jeffrey B. Klein if you have any kind of foot issue, because it's very important, because our next topic is diabetic foot care. But let's go back. What people are trying to do and remove an ingrown toenail by themselves. What is your procedure that when we come to see you for an ingrown toenail, what really happens with Dr. Klein?
So it depends if it's infected. It depends if it's come before and then it's gone and comes back again, that type of thing. So we evaluate the patient, whether it's a child or an adult, a senior citizen. We'll basically evaluate their circulation, make sure they have good circulation to their toes, and then we remove the corner or the offending border of the toenail. So you're not removing the entire toenail, but just a sliver in the corner of the toenail. At that time, we go ahead, if it's something that's come back over and over again, sometimes we'll actually put a medicine in there so the corner of the toenail does not grow back. Not the entire toenail. The entire toenail is there, it's just a little narrower. And 9 times out of 10, or 9.8 times out of 10, it will never grow back the ingrown portion of the toenail. And therefore, you won't have any more pain or infection. Sometimes, if infection is present, you need antibiotics. Sometimes we do home soaks with different types of antibacterials, such as white vinegar or warm soapy water. Just depends on the condition. But this is something that's done in the office several times a day because ingrown toenails are so common. The problem becomes if somebody has an infected ingrown toenail and they leave it go, they live with the pain, or if they're a diabetic and they have neuropathy or numbness in their feet, then they don't feel it, they don't check their toes, and it becomes infected. When it becomes infected over a long period of time, the infection can actually go deep down to the bone. And of course, you want to avoid things like that. You want to get this treated as soon as possible, because if it does get infected down to the bone, then there is a much more aggressive type of treatment. We work with infectious disease doctors who will a lot of times start these patients on antibiotics for a long period of time, whether it's given by mouth or whether it's given in an IV. Sometimes it requires even more types of surgery. Patients who have poor circulation or as diabetics sometimes require debridement, or basically removal of a portion of the infected bone. These are in extreme cases, and this can really be avoided by looking at your feet every single day of your life. And if you see a problem coming into the office, sometimes there's just a very simple fix for it by allowing me to trim out the corner of the toenail versus doing some type of procedure. So do not let infections linger and think they're going to go away, because sometimes they will, but sometimes they won't.
What is the difference, Dr. Klein, when you have an ingrown toenail and it gets infected? What is the difference between that infection and something like a foot ulcer? Is it completely different? Are there similarities? What exactly is the difference between the foot ulcer and like an infected ingrown toenail?
So an infected ingrown toenail is the corner of the toenail, or the pointed part of the toenail, irritating the nail fold, or the fatty part on the side of the toe, which causes irritation, a break in the skin. And the skin, remember, is a natural barrier to infection. Once it does that, infection can get in. If you're not a diabetic and you're a young child, it's a very simple way to take care of this. When you talk about ulcerations, that's a whole different subject, and it's usually seen in people who are diabetics, who have poor circulation, who have bad varicose veins can lead to ulcerations, and who also have poor circulation. And it's usually caused by the way you walk, the bony anatomy of certain people who have like hammer toes or bunions or bumps and lumps on top of their feet or on the bottom of the foot that is irritated. And the skin can break down due to the walking or the rubbing of shoes, or both. And the skin, once again, is the natural barrier to infection. Infection can get deep down into the bone or into the soft tissues and require aggressive treatment.
Dr. Jeffrey B. Klein, as always, more information. I can't tell you how much the listeners and I appreciate you taking the time out of your busy schedule to come here and talk to us. Ingrown toenails are a serious thing. We need to come see you. I know I'll be there yet again in your office. and can't wait to talk to you again. I understand that diabetic foot care is another topic that you are a subject matter expert on. So looking forward to talking to you again soon. Thanks, Dr. Klein.